I'm Dr. Alex Schmidt. I'm a forensic psychologist with a kind of multi-pronged practice in Los Angeles, and I treat primarily the symptoms of severe early childhood trauma. It has branched out for me into a lot of different places, but primarily it's perpetrators and victims of sexual violence are the kind of populations that I work with the most. I work with, I do risk assessments for the courts where people are, excuse me, about to be convicted, generally speaking, of some sort of sexual crime against a child. And I try to help the courts understand what has happened, how that person may have come to those behaviors or those actions, where and if there are places where they might be amenable or appropriate for treatment, things like that. And then on the other end, in my private practice, I see kids from the foster care system who have histories of pretty severe and extreme trauma, being trafficked, things like that, who are not responding to kind of standard staff therapeutic interventions. And so they retain me to treat these kids who have sometimes shut down or have gone mute or are acting out in ways that are violent or inappropriate, either against themselves or other kids. And then there's other things in the mix. I teach and things like that. I work with probation officers a lot, helping them understand kind of what's going on in the population of people on supervised release.
Yeah, great. Okay. And Alexey.
Hi, I'm Alexey Tolchinsky. I'm a clinical psychologist in Maryland. So I do clinical work as a day job, most of it. And I work a lot with anxiety disorders, including obsessive presentations. Alex and I share the interest in trauma. I work with acute PTSD, complex PTSD, and attachment trauma, but not to the level of severity that Alex works with. I mean, this is very noble work that you're doing, very hard work. I also work a fair amount with immigrants and people who go through life transitions, such as young adults trying to be in college and survive it. Or people who go through divorce. A fair amount of my practice is neurodiverse individuals with dyslexia, dyspraxia, Asperger's. And I've been writing papers on different topics related to neuropsychoanalysis. And, Michael, you and I recently, and George Ellis and Sarka and Jeffrey published a paper and discussed, but that's also my interest. And I very much look forward to this. I learned so much from both of you, and it's educational for me, and I really appreciate it.
Yeah, fascinating. Yeah, well, I'd love to hear you guys talk about what led us to connect in the first place, and how you see your work connected with the kinds of things that we do. It's super interesting to me that we do work in frogs and worms and cells and things like that, and we get a lot of outreach from people who work in therapy and in the psychological sciences and so on. And it's very interesting to me what those connections are and what you guys see there. So I'd love to hear more about that.
Sure. There's more overlap than not, I think, at this point. The thing that brought you and I together, Mike, was I was reading The New Yorker, a magazine that I no longer have time to read, so it wouldn't have happened. But I was reading an article in The New Yorker about the work you were doing around regeneration and the idea that a cell could be nudged to replicate or to heal something, to finish a feedback loop where there had been traumatic injury, right? And in here, one of the practices that I'm building and working on is based on the idea that I strongly believe that the somatic piece that we carry as a result of trauma, whether it is trauma from childhood or even trauma that we carry from previous generations, things that have happened recently or long ago, it's all held as a cellular record, right? The body is a living record of those experiences. And, I look around at many of my colleagues and we are treating trauma downriver. We are treating the symptoms. We are managing the hypervigilance or the anxiety or the panic attack or the dissociative moments, but we're not treating it upstream at the source. And it seems to me that the more we are able to find and access the source places, the more we are able to facilitate then a downriver repair, right? So not just playing whack-a-mole with the things that are happening as a result of trauma, but actually shifting the kind of the shape of the rings in the tree that hold that memory, right? That's going to impact people on a somatic level across domains, right? Because we see all of these different manifestations of it that perpetuate, right? High blood pressure and inflammation and all of these different, I mean, I could list 20 different conditions that are connected to those kinds of experiences. But in here in particular, I have more questions than answers, but I think there are practices that we can engage in ourselves that would necessitate facilitation at first, but I think the call can come from inside the house to repair some of these systems. And whether that is, I have a research interest and a whole other lane with the brain and the impact of the way our brain structures affect our feedback loops, the PTSD, all the axes that are affected by that. But I think there are things that we can do even on, I mean, my youngest client is 5, right? And my oldest client is like 85. But even on the level of my little kids, there are things that we are beginning to play with that I think are activating potentially a cellular cascade that could help with repair. I mean, you and I've talked before about kind of how to document that or how to follow through. That's kind of what brought us in. Where I read this article and I was like, I have to talk to this man. So yeah, that was the entry point.
Yeah. I mean, it's very interesting, right? Because there's a couple of things here that are strong themes for us. So this idea of chasing down the ultimate manifestations of things, the symptoms, is mainly what a lot of medicine today is about, right? Is that we have ways to address specific symptoms, but it doesn't actually fix anything. It doesn't get to the root cause of it. And I hope today we'll talk more about some of these issues with somatic memories and some other things that I wanted to ask about. So. Yeah, for sure. Yeah, and Alexey.
Well, I had several phase transitions in my development, and Mark Solms and neuropsychoanalysis discovery at the 3rd year of my graduate program was one of them. Chaos theory was another. And your work, Michael, when I found out it, through maybe chance events on YouTube and following Carl Friston and Mark Solms, shook me to the core. It was a big pivot because, we have been taught all along about the singular intelligence, singular consciousness, the cohesive sort of, and, your thought that we have intelligence at the level of skin cells just completely changes the outlook on everything. And then I started following and reading your papers and watching your lectures with gratitude. But I think that, part of me was like, why haven't we been taught that? Part of me is like, we need to introduce it to the graduate programs in psychology and psychiatry. It's revolutionary and useful. And also, I think that, I found a lot of resonance in what you shared, in your technological approach to Mind Everywhere paper and TAME, and it just resonated with Carl Friston's work. And this is why I think I approached you for this depersonalization paper, because it's a powerful instrument, a powerful prism to look at the clinical phenomena that Alex and I work with, and very useful, I think.
Cool. Yeah, I'm really interested. I mean, the experiences that you guys have clinically are it's such a no doubt important body of knowledge for what we can do both biomedically and in model systems. We have such a limited ability to see the different cases, of the manifestations of memories and somatic, the somatic impact of different kinds of memories. So this is the kind of thing I really want to dig into. One thing that I've wanted to ask you was from a clinical perspective, to what extent do you see the ability of, and I'll go further with this in a minute, but just to start here, like the ability of specific memory or behavior patterns to perpetuate themselves. This idea of, right, because this is something I'm working on now very very heavily, is this idea that, okay, originally we can think of, there's an agent, there's the, let's say the human patient, they have a cognitive system, they've got a brain and some other stuff, and within that there are patterns that are memories, and we can, but they're passive data, and we can talk about how the agent processes that information. I want to flip it around and ask, what if we look at things from the perspective of the memory patterns themselves? So this notion of William James has said that thoughts can be thinkers, right? Thoughts are thinkers themselves. So this idea that, we too are temporary dissipative patterns in metabolic media in a certain sense. And so we can look to other patterns to see what degree of agency they might have. And one thing that they might do is want to perpetuate themselves. They might do a little bit of niche construction to manipulate their environment. And this could be synaptic mechanisms, but it could also be lifestyle. It could also be behavioral, putting the person in certain environments. What can you say about that clinically? Is there a phenomenon where some of these patterns, repetitive, intrusive kinds of thoughts, these kinds of things, depressive thoughts, PTSD, complex, all of this kind of stuff, do you see it in a way that it changes the physical and the kind of behavioral aspect of the patient so that they are more likely to persist? They kind of persist their own survival. Is that something that you guys see or no?
Yes. If you'd like, Alex, I can maybe share a viewpoint,
Yes.
and I'm sure you will share the traumatic examples as well. But I think one of the features of your question, Michael, is the loss of the sense of agency, where we feel like we have no choice anymore. And I think that this, I use the term hijacking of the train of thought in the course of action, can happen clinically for multiple reasons. Obsessive compulsive presentation is one of them. Delusion is another. A craving and addiction is a third one. A post-traumatic flashback is yet another one. And all of these sort of scenarios have something in common that I wanted to maybe mention. But I think that, it's useful to have an example that is a bit more extreme than personality, but clear, such as obsessive compulsive disorder with Hijacking subtype. Let's say I leave the house and I lock the door and I step away 3 feet, and thought pops into my head: what if the stove is on? And the thought is powerful. It's something I can't not think, which is what we call obsession. In addition to it, there's a push, there's a drive to open the door. It's the impulse to act that I can't not act, which is what we call a compulsion. And these things we're pretty much aware of most of the time. What we're not aware of, I think, is what is maybe missing in the question is the entire regime, the state of the mind and the brain and the body. Because if we attend to it, we'll realize that we're tense. There's some tension. There's some threat. Specifically, what if the house burns down, right? And that has anatomy and chemistry and profound effects on everything: attention, perception. The bed nucleus of string terminalis fires. There's cortisol. There's vigilance. But perhaps we can call it anxiety, which is a state of uncertain threat. And this is, I think, is the key component that actually does the hijacking, while the thoughts and the actions, the compulsions, are maybe the tips of the iceberg that manifest. Worry, the what if the stove is on, is a cognitive component of anxiety. The impulse to act is a behavioral component of anxiety, it's compulsion. But the whole tone, the whole state, the regime change of the body is important. And in and of itself, for an emotional state to hijack the course of action is normal. Let's imagine that I'm reading a book on accounting, which is emotionally neutral, and suddenly I feel air hunger. Like, what if I suffocate? If I don't attend to that feeling, I die. And we have, of course, the internal hierarchy of needs, where air hunger will be more important than thirst, which is more important than hunger, et cetera, et cetera. But we can trace this sort of idea of an emotional state hijacking the behavior, even on a single cell organism, such as, I don't know enough about planaria, but Kevin Mitchell has an example of paramecium in his book. And let's say paramecium is busy searching for food. It is moving toward the gradient of, food. And suddenly it's getting bumped from the back, which to paramecium means you're being attacked by a predator. If it doesn't change, it dies. This redirects, this, if you wish, the sort of proto-fear reaction changes the course of action and changes the plan abruptly. And that's the example of hijacking. And because emotions are usually survival needs, and where it goes, south in psychopathology is when emotional system is dysregulated. Then we fire and we get hijacked for pretty much no real reason. So, such as if I did go and check the stove, came back, close the door, and I walk away 3 feet, the thought pops in right back. What if the stove is on? And the compulsion is right there. So then I'm detached from reality. The reality testing didn't update my supersalient belief. It is still hypersalient, and I'm compelled to do it again. And I'm sort of stuck. And this, maybe I should stop talking here, is one of the examples of how this sort of hijacking, loss of sense of agency happened in a specific presentation of obsessive sort of kind. But maybe I'll, Alex, or you have any other thoughts about it?
Very interesting.
Absolutely, yeah. And don't, at least not for me, please don't self-edit. You can you can go on. But and I know that you, Alexey, work more with OCD as a specialty. It is something that I experience as a kind of side effect of deep trauma with some of my clients, although I do have some clients where that would be the predominant or sort of the prevailing headline diagnosis, right? Is that the OCD has kind of taken precedence over the other things, but they're all connected. I relate to obsession. And when I say obsession, I'm talking about involuntary obsession, right? I'm not talking about the fact that I have a lot of vintage mugs in my house. That's a different, that's on purpose. But when there is that lack of agency, but there's still consciousness around it, right? And you illustrated it beautifully because there's that sense of like, what am I doing? But here I go, right? Where the conscious mind is observing, but the subconscious is driving, right? And that is a very profound feeling of helplessness and frustration that has somatic components to it, right? So when I look at, particularly at OCD, I think of the obsession as it's our survival drive. That's a reflex. That is the fundamental, if you talk about that kind of hierarchy of needs, not getting killed is the very bottom of that platform, right? Do not die, continue to carry on. And that is not a decision we make. That is something that our brainstem is monitoring all the time. We're not looking at someone in the supermarket thinking if we should kill them or not, or if they're a threat, but subconsciously we are all the time, right? It's exhausting. And obsession, and you know this, I think you referenced it, it's largely checking and cleaning, right? It's those two things. It's contamination or am I safe? Is the oven off or is this dirty, right? Those are the two places where those come in, and those are fundamental to survive. If we are either in immediate danger or we're going to be infected by something, it's game over and nothing else gets to come in. But when we see OCD, we see this misfire. So it's the survival drive going, what if, and we're not able, and we know in the brain structure too, right, that people who live with that have a smaller volume in certain parts. And this is more pronounced in DID. I know we referenced, Alexey, you and I were talking about that a little bit in an email, and this can come in later, but in obsessive brains, there is this misfire where the thalamus is not getting enough stimulation and the oxytocin or the endorphins are not coming when we've completed the task. So you turn the oven off and you wait for, it's like you stick the landing at the end of your gymnastics routine and you're going to get some endorphins or some oxytocin, but in an OCD brain, you don't. And so it propels us to do it again, right? Because we're searching, kind of like trying to push the lever to get that reward, and it doesn't come in, and it creates and scales up somatically into anxiety, into shame. And I'm saying somatically, but referencing emotional states because they're all playing out physically, right? Your blood pressure goes up, your heart races, there's an adrenal cascade that happens, and those things begin to accrue momentum over time. This is why we see people who are, I had a client who was bleeding from having washed his hands so many times that the skin had cracked, right? And he's trying to function while trying to satiate that impulse. So I think it's a kind of an old reflex that occasionally misfires. And then we can talk about how that plays out physically as well.
There's one part of what you shared, Alex, that I wanted to pick up on and maybe hear what you think is, in addition to this sort of emotion, which is front and center important in OCD, and just to comment quickly, I think, Michael, Alex, the checking is a different subtype and a different presentation from contamination. So this paper that Michael and I and George and Sarka and Jeffrey wrote was about disgust activation. So if we're talking about post-traumatic OCD, then if a person was in a terrible event and he witnessed a terrorist blow themselves up and pieces of flesh landed on the skin, and they may develop a post-traumatic contamination obsession washing compulsion, which is qualitatively different from checking. This is sort of a hyperactivation of disgust. But to go back to one other aspect of it, there is automatization in OCD. There is habit formation where there's a cycle where we get stuck. I like the metaphor from Norman Deutsch in his book, The Brain That Rewires Itself, where obsessive tendency is sort of like being stuck on page 16 and being unable to move the page, right? And I wonder if Michael has examples. I don't know enough about biology of perhaps a planarium or another organism making a repetitive behavior that is not functionally necessary. It's just getting stuck in a loop doing something that we can't place. But you've mentioned thalamus, and I think these people talk about the cortico-striatum thalamus cortical network. And what the interesting experiments now in OCD animal studies, not even human studies, is using optogenetic in mice. They were able to activate the projections from basolateral amygdala to the medial prefrontal cortex, and the mice started showing check-in behaviors. So we can induce that state, through the activation of a certain neuronal network. Again, in Michael's, on a network level, not a level of singular molecule or something like that. But this habituation that I know, Michael, you talked to Ian McGilchrist, who did a lot of work on sort of routine, stable, highly optimized, behavior, which he called left hemisphere, and the sort of spontaneous, novelty-seeking, exploratory behavior, which he called right hemisphere. But I think that in OCD, it very heavily gravitates to that routine, to that sort of, and that's a completely also basal ganglia is involved in that, and other areas of the brain are involved in that. But I'm interested in the biology of how it becomes that sort of cycle where we get stuck, So.
Yeah, I mean, there certainly are examples of overgrowth where the normal checkpoints that say, okay, you've reached the location in morphospace that you were trying to reach. Your skin is contiguous. The volume of your tissue is correct. You've got the right number of fingers. Whatever it may be, where that doesn't trigger the cessation of growth, and the cells continue to, kind of abnormally proliferate. There's also kind of the old description of cancer as the wound that never heals. And, I think that has some truth to it. I don't think it captures all of what's going on there, but I think that has some validity to it. So, I mean, there certainly are these kinds of phenomena. I wonder, I'm curious if you guys can, if you have any thoughts on or maybe you might think that this whole idea is not the right thing. But I was in a recent paper I floated, again looking at things from the perspective of the thoughts, from the perspective of the patterns, right? What does the world look like from the perspective of the patterns? And I try to kind of flesh out a continuum where you could imagine you could have fleeting thoughts, right? These are cognitive patterns, they come and they go, right? And then you might have intrusive / persistent thoughts that tend to stick around, and they're a little more persistent, and maybe they actually, as we talked about, maybe they actually even exert some changes on the brain and body to help them stick around. And then after that, you might have something like a dissociative personality alter, which is way more than just a persistent thought. It has a cohesion, it has its own opinions, and so on. And then eventually, you sort of have a full-on personality, and who knows what comes after that. But that's sort of like a spectrum that I imagine. Can you think of any other waypoints on that continuum? Are there any other phenomena, especially clinical phenomena, that are missing? What else exists in between these kinds of? Because I feel like some of these are very far apart. Like, what else? Can you think of anything else that belongs on that spectrum?
Well, the first thing that comes to mind when you talk about that is the aspects of fragmentation, right? In the way that when we connect, or if we compare cancer essentially, at least to my eye, is a kind of cellular misunderstanding, right? I am suddenly being attacked. I must return in kind, and the cells begin to attack in our own body. And we see this in what it reminds me of very much is the way that we wall off in deep trauma. We dissociate reflexively, right? When something is too much for us to integrate, and that is just I compare it with my kids. I'm like, if you're trying to move a couch through a door, that's very difficult. If you're trying to move two couches through the same door at the same time, it's impossible. And that happens often with people. We get overloaded, we dissociate, and so the physical and the intellectual experiences are separated, and it's a surge protector. It's a way for us to put these things into manageable places and tend to them in time. Now, for most of us, we don't lose the memory of where we put those things, right? We know what happened. We just might not be feeling all of the integrated, the sort of symptoms of that. When we think about it, this is why people come to therapy, is to put those pieces back together. And the fact that it is protective allows us to keep going. With deep trauma, and Alexey referenced this with the kind of more with the disgust, with the revulsion, and with also typically it's not just fear for loss of life, but it's related to bodily fluids and things like that. So if someone is attacked in a way that blood or other bodily fluids are involved, that tends to trigger a much more kind of fundamental nervous response. And we see this in the PTSD presentation, because there are, I know you probably all know this, but you've got your more common PTSD, right? With vigilance and preparing to fight, right? We all talk fight or flight. And then there's a subtype where 10 to 15% of people, and it's more closely associated with that deep trauma and that overwhelming, two couches at once sensation, have a different reaction, and they go into syncope. They go into syncope reaction, that is collapse, that is shut down, that is play dead, right? And so those two, when you have memories with this kind of experience, people talk about, it's a touchy subject, but people talk about recovered memories. And in my experience working with people who have that relationship to their past, it's not so much, the sort of cliche is that it's pulled whole cloth suddenly and you remember the whole thing. It isn't like that. It's on the shelf. It's there and present, but it's kind of protectively abscessed, right? There's a layer of recognition that has not yet been penetrated. And so talking about obsession, and particularly involuntary obsession, moving into or becoming a place where fragments are happening. Now, I don't really relate to OCD as the spectrum that becomes DID, right? That becomes a dissociative disorder, although there are elements of dissociation, particularly when people with OCD are engaging in those practices, right? You kind of tune out a little bit because you're tending to something else. But the fragmentation that we see in DID, and my experience with it is limited. I've worked with a couple of clients, and I did a big eval on one particular case that came in, but it's fragments that are holding the whole together in order to perpetuate survival, right? This experience, this age, this identity is over here, this one is here, and you kind of take them all together and you get a sense of the person over time, right? And I think we see that sometimes in disease models as well, but I have more questions again than answers about how physically that happens and is supported. There's definitely a neurochemical component to that, right? But maybe Alexey can speak more to what he's thinking.
Yeah, I very much am interested in what you're sharing, Alex, and specifically the fragmentation, but I'm tempted, if that's okay with you and with you, Michael, to take a little bit of step back to the question of thoughts. Because Mike, I think you asked about classification of thoughts, such as fleeting, intrusive, dissociative, and just to share, maybe this is an oversimplified perspective, but I think thoughts are stable things in the mind. For example, if I have a thought that I need to go to a grocery store, it's an audio verbal thought, but I keep it in my working memory for the time being. It sits there, and it is constructed as a sequence of words. I can have a visual thought, such as an image. I can have a musical thought, but they stay in working memory for a while. And in that regard, they're a bit more deterministic than emotions. I think emotions are always a flow. Emotions are cascades, such as a fear cascade or something. And so they're different things. And we can sort of average them out on a higher time scale, such as saying that anxiety is usually lasting. It's a state, of uncertain threat, while fear is a flash, high up and high down. I only mention it just to maybe try to, in my head, clarify these things. I like Mark Solms for many reasons. One of them is that he's a very clear thinker, So I think that and from the standpoint of neuropsychology, I think thought is not that different from an action. As I said, there's a sequence of words, and if I get up from this chair, there's a sequence of contraction and relaxation of the muscles that I've learned. It's a memory, it's a procedural memory that, infant doesn't know, and then we develop it and we have it. But in OCD, there's a proclivity, and even in milder things like obsessive tendency and a personality that Michael you mentioned, to do and think, and not to feel. There's a certain isolation from the body, isolation from the emotional tone. And to the question you're posing, Michael, about personality formation is extremely complex. But maybe briefly, one of the small parts I wanted to say about it is that I like Frank Putnam's take on it, and Alex probably knows him well, is a renowned traumatologist and specialist in dissociations and researcher. But he talks about a collection of mental states or brain-mind states, right? And we know that term well. There's a state of being awake and state of being in REM sleep and state of being in deep sleep. And there can be a state of hyperarousal, a state of being obsessive, right? And so we can say that as the baby matures, baby develops a personality, which is a certain pattern of states. And Carl Friston called it a manifold or an attractor of states. And there's itineracy of going from one state to another. Now, in trauma, for example, or in the onset of psychopathology for another reason, that landscape changes. The attractor state becomes different. And then, as opposed to saying a coherent self, in autobiographical component of self, we can start getting alters in DID and sort of hop from one to another. But this is the change in I think, psychopathology. And in personality formation from childhood is gradual, and then it sort of solidifies, hopefully, into some stable personality pattern. And in trauma, it's abrupt. And we see neurological changes in that. A classical example is Phineas Gage, who was a railroad worker and had a rod going into his brain, particularly in the ventral medial prefrontal cortex, which is involved in impulse inhibition. And this person who was very gentle, cordial, kind, and nice became obnoxious. The abrupt personality change from a neurological injury. But there's many other examples of how personalities change in aging, in Alzheimer's, in trauma, in stressful environments such as COVID-19. But I think I've probably said enough and possible.
If I can, it's so interesting because there are so many places where we overlap, and then there are places where our interpretations are very, very divergent. In that, I experience, or at least I have observed, that thought is always concurrent with emotion, right? That the way I describe it is that we have these three gears going of our lived experience, our interpretation, which is both intellectual and emotional, and then the physical manifestation of that, right? In the same way that they're as everything in light casts a shadow, those things are connected. And very often, I think, and perhaps more maybe in here, I see that thought is kind of last to the party, where the physical memory or the physical association rises first, right? And then produces sometimes a narrative about it. But we can't talk about trauma without talking about because you have some people who experience one profound horrific trauma, and you will see the splintering, you will see the creation of different, even entire identities, right? Personality shards that are kind of walled off from one another. And then you have another person who's gone through, God forbid, but 12 of those situations, and they're perfectly fine seemingly. And they, drink coffee every morning and work a job and aren't troubled by X and Y, or perhaps they have, a different kind of therapeutic relationship, hopefully, to deal with that. But why does one person develop this and the other person seemingly continues to integrate? And so the predisposing factors to that, right? I mean, I'm sure you're all familiar with the analogy for PTSD, that you have a vase that's been hit with a small hammer and there's a little crack, right? And that is the person who maybe is relatively intact, relatively prepared, or fundamentally more ready to absorb other issues, other trauma. There's going to be a small crack. But then you have someone who might be more the equivalent of a vase that's been tapped 100 times before, right? And something comes along and it falls to pieces, right? It's this sort of the tipping point. And what determines that, right? Is it resilience? Is it the personal capacity to resource and cope? Is it things coming in that we're born with, where we are prone to hypervigilance, that major startle response, high blood pressure, inflammatory reactions, etc.? Is it a combination? Is it this life stressors? Is it our capacity to resource ourselves? But we know that there are physical differences that make us susceptible to it, right?
Is is my understanding is that trauma is a major initiator of this, but is there anything else that causes dissociation? Is it always like in, you know, in serious dissociative identity disorder, is it always trauma, or is there anything else that can lead to that?
Alexey, you want to speak first?
Sure. I mean, I'm this wonderful book by Frank Putnam, The Way We Are. Again, I think that if we go back to the history of this, William James tried the funny gas, is it nitrate oxide, and he experienced certain things, and he developed a strong interest. I think substances were prior and to the dissociative states. When we talk about disorder, full-on DID, full-on PTSD, I mean, we're talking about most often with traumatic events, but I think a neurological issue can lead to dissociations. When I spoke with my colleagues who are experts in DID, and I said patient HM or Clive Waring, who have bilateral, damage to hippocampus, and they live in the here and now, they say, well, if I were to look at his presentation, he looks perpetually depersonalized. There's no continuity. They live in the fragment. And that's in neurology. Then chemical, yes, ketamine, psilocybin, high doses of THC will result in a dissociative experience. What else? But I think it's probably useful to even define the terms, because I've seen people define dissociation as a very nuanced, very small things where all of us experience a benign dissociation every week, and then a big sort of pathological state. But stress perhaps can cause these things as well. And when we talk about trauma, I think we're talking about extreme stress, overwhelming stress, where the stress regulation network in the brain, including HPX, is flooded. And we have inability to cope with what's coming at us, which is one of the theories, is that hippocampus becomes inactive because it has a lot of cortisol receptors, and we're flooded with cortisol in an acutely traumatic event, which is why we don't encode a stable episodic memory of the event. There's shards, the fragmentation that Alexey talked about, pieces of semantic memories, pieces of procedural memories, phobic memories, but there's nothing that glues them together coherently and cohesively. There's this sort of gap, or sometimes it's a full gap of traumatic amnesia when, somebody experiences a murder or of a loved one. But that's these are maybe my thoughts about it. Yeah.
Dissociation is so it's difficult to pin down, right? Because it is, at least to my eye, one of those things that is happening continually, right? You called it, I forget, Alexey, the phrase you used, but kind of what we would think of as day-to-day dissociation, right? And dissociation is necessary to do anything. If we were continually, it's so interesting because the definition of sanity itself is the appropriate integration of emotion, events, and personality, right? If all those gears are meshing, then we are thought to be, functioning relatively well. And yet, even within that, if we were immediately emotionally impacted by everything that happened throughout the day, it would completely overwhelm us. So there's always this level of dissociative, like a buffer, like kind of a gentle, like a soft focus, right? Like an Instagram filter that's happening, but it becomes sometimes involuntary and overwhelming, right? And that is definitely a sense of the wheels coming off the bus for people who were able to, this is the difference too, right? Is when we are having it, for example, if I see something, I don't know, irritating happening, and I don't immediately give in to my feelings of it, and I'm not swept away with it, that's appropriate. And I'm aware that I'm managing that, right? There's a meta awareness, which is also an element to that idea of sanity. I mean, that's a rocky road to get into, really defining that. But when it becomes involuntary, it's a whole nother matter. And you mentioned the HPA axis, and that when it's overtaxed and there's too much cortisol and there's not that feedback loop happening, right? It gets there in a million ways. There are those kind of headline news traumas that get there, but there's also the systemic kind of piece by piece overload, that ongoing stressors, even like microaggressions, little things, little tiny, I use those because people are aware that you can't put your finger on it. And you can't point to one of those and go, well, this guy looked at me in a way that was patronizing and now I have trauma, right? But if that happens to you 20,000 times, they collectively become a traumatic experience for the brain to hold. And it can also send us in that. This is why I'm so interested too in the different things that send us down that road.
Mm. Yeah, that's a very interesting point. You know, this the kind of the smaller version of it. The reason I asked, it's kind of a weird reason, is this Bernardo Kastrup and Rupert Spira expressed an old idea recently, that they said that, you know, all of us are kind of dissociative alters of the great universal mind. You know, this was this idea that we're all kind of in sub personalities of this like giant universal consciousness. And I heard, you know, when I was thinking about that, I was thinking, well, so what caused the fragmentation event, right? Because, you know, if you're the universal mind, what is causing you to fragment in the first place? I mean, you know, for us, we typically think about trauma and then the things that you just said. But I wonder if boredom, or this is a severe version of it, like sensory deprivation or something. I wonder if that's a thing, because really, if you are the only mind around, if you that it's just you, and you're massive, and so every theorem is that's a tautology to you. Everything is kind of obvious. There's no one to talk to, nothing to, you know, that intuitively that seems pretty stressful, and that you might think that would just cause it right there. But I don't, you know, I don't know. That's what I was just sort of bouncing this off. If you think that's a reasonable addition to their theory of how it gets going.
I'm struck by the two opposite ends of that. If you're talking about like either the universal consciousness creating kind of sentient life in order to amuse itself, right?
Yeah.
Which is a pretty potentially yes. And then we look at when, and you probably know about the Romanian orphanage study. Those during the there was a time when Ceausescu was in charge, when the orphans there were a lot of orphans going into the facilities, and the nuns who were tasked with taking care of them this is not a criticism of the nuns, by the way, did everything they could, but it had to be this like Henry Ford factory style. Every day it's time we change all the babies. It's time we feed all the babies. It's time we change them again. Okay, now it's time to bathe them, right? They had to do it just to keep going because there were too many. And so these children were essentially warehoused in cribs, like little filing cabinets, with no stimulation, no attachment-based responsive, I mean, attunement. And you know, the mirror process that goes on is what stimulates that growth, right? So they were left to their own devices. And years later, when Ceausescu was overthrown and they came in, these kids had their brains. It is, I use the slide in a study, but I always give people a trigger warning because it's just really difficult to see. Their brains were shrunken. And the families who adopted them talked about how these kids were not only internally attuned, right? The only thing they had to play with or amuse themselves was their own hands. So they were completely like inwardly focused, but they also recovered to an extraordinary degree, and even to a limited extent, some of the recovery of the actual physical matter of the brain rebounded upon being placed in contact with people. And I say this as an introvert, as a deep introvert. It bothers me to admit that we do have to have this contact, and yet it's necessary, right? We just have to find ways to titrate it to what we can bear. Or that sounds horrible, what we find pleasurable.
Yeah.
I think, Alex, you highlighted one. This is an extreme example of Romanian orphanages, but I think that what we see often correlates with psychopathology is a disorganized attachment style. And these children, they experience severe neglect, which is often more harmful than abuse. And they also had abuse. And so they have a lot of integration is being taught. A lot of integration is being felt and experienced between the baby and the mom from birth. And their developmental period is significantly different from other children. So and I also wanted to go back to this key term you're both using, fragmentation, which to me, bear with me, is a spatial term where something broke, right? And I think that we're talking about sort of this idea of breakage, and what Michael mentioned, the boredom leading to maybe fragmentation. If we go from space to time, then to me, the analog of that is discontinuity. What does it mean that patient HM lives in the like 10 minutes of the here and now? Is there's no continuity into the past and into the present. What does it mean a flashback? Flashback happens and I re-experience what happened to me 10 years ago. I broke from the here and now of the, you know, where I was, right? And so this work that we're doing now, Michael, with colleagues about the depersonalization, is that there's disruption not just in space, but in time as well. And can it be benign? Sure. When we wake up, we're not immediately back to who I am and where I am and what's going on. It takes us a little bit to get oriented in space-time and everything else. Is it Tuesday or is it Wednesday? Not immediate, right? So we go through these sort of dissociative experiences, if you wish, many times, but then we usually, and then your favorite example with propofol and general anesthesia, talk about complete, utter, biological fragmentation and discontinuity. But I do think there may be benign examples of both fragmentations and discontinuity in time.
We have to, if we're going to talk about fragmentation of in any kind, and I appreciate the way you illustrated that. I think we have to acknowledge that most behaviors, whether involuntary or voluntary, tend to be preparatory in service of survival. In other words, it's paranoid thinking, right? It's rarely, almost never, preparation for something good. And that is because we needed that, and we still need that in order to get through the day, to not get killed, to not be contaminated, etc. And we don't need to pass on to our children, genetically speaking, the knowledge that cake is delicious, right? They're going to figure that out on their own, and it's not going to kill them, hopefully. But we do need, and we always need, to be on the lookout, in a sense, which is that patrolling, perimeter checking part of us that is monitoring for that. And when we see it getting out of balance or out of control, when there are misunderstandings on a cellular level, and this is, unfortunately, I'm sure, Alexey, you deal with this too clinically, people don't tend to come in with really happy, pleasant things that they do obsessively, that they're like, I'm having too much fun, I think I should go see a therapist. It tends to be something that is very much related to dread and survival, right?
Although I assume that somebody else might send them, right? If they're having too much fun obsessing, somebody else might say, you might want to go see someone.
Possibly.
Yeah.
They're not coming into my office, but
yeah.
We have a joke about that, Michael. It's how many psychiatrists does it take to change a light bulb? One, when the light bulb is ready to be changed.
That's pretty good. Good. Could we talk a little bit about somatic memory and what are your experiences around the rest of the body carrying things that can be treated as a memory medium? To what extent is the body a memory medium for behavior, for personality, and so on?
Oh my God. I mean, I think it's well, first of all, they're inextricable, right? They become sometimes separated. These memories are held, placed, shelved in different ways, but the record is retained throughout the body. I find, particularly in trauma work, it's so interesting. And we all have like smaller experiences of this, right? We all have maybe if you're sitting in a movie theater and someone grabs your shoulder in firmly, we jump, right? There's a reflex that we don't go, oh, I bet that's someone who's very happy to see me. We are all prepared in that way for a bad thing to happen again, right? There's that kind of, and these are just, basic human reflexes again, because we're wired for bracing for the worst in many cases. But somatically, when those things come back, it's a delicate process to sync up the body and the experience, to put the words with the music, because it has already been experienced as unbearable, which is why the dissociation has happened in the first place, right? So to cultivate a relationship with someone else where you are going to consciously bring in and speak to, and I do this with really little kids, and I do this with adults. There's a obviously different language that's used, but to return to that place, even though it's not happening now, the body remembers, right? It's keeping the score, as we all know, and those reactions will present to be integrated in a space where I call it stepping in and out of the boat. It's like you have one foot on shore, you're putting your foot in the canoe, and when it starts to feel shaky, you come back. That's the reparative process, right? Because you're no longer being pushed out beyond your capacity to have agency. You are agentically empowered. You are deciding to return to that. And then a lot of times those feelings will come in, right? The trembling, the adrenal stuff, the stomach and the throat. This is sort of our, like the fire plug shape of our emotional highway, right? Pain is read and remembered along these paths. But when we are able to touch in on it piece by piece, we see repair.
I'll probably try to add to what you shared, Alex, and it resonates, but maybe also with an example. I'm trying to filter it so I don't disclose anything about patients, but what happens often in trauma work is the patient says, I feel very off and I don't exactly know what it is. It's decontextualized. It's sort of no content, no meaning, no nothing. And I say, tell me about how it feels in the body. And they will tell me a specific profile, and I won't mention details, but let's say tightness in the chest, okay? And then we do a psychodynamic thing sometimes and say, just relax, don't think, don't analyze, concentrate on that state of your chest, it's tight, and tell me what pops in the head. We're doing a memory thing, so because memories are stringed together through associations. And oftentimes, I had several experiences like that. The patient comes up with an event that happened in their lives, which was traumatic. So I just wanted to add to what Alexey shared. It's not a brainless somatic memory. Certainly, central nervous system was involved, but this is how it laid down. The state of my body was the trigger through which the person not really recovered, but talked about something that we haven't even mentioned in like a year of work together. That was indeed overwhelming, traumatic, intrusive, and other things. So does body keep the score in that regard? Perhaps. But I think it's a component, and these traumatic memories, they're like trees with multiple roots. They have physiology for sure, but they also have a specific emotion in there. It could be a little disgust, it could be fear, it could be other things. So when we say somatic memory, and this book Alexey mentioned, Bessel van der Kolk's book, The Body Keeps the Score, in my experience, a lot of people sort of not professionals, but they take it a bit literally by just saying that this sort of itch in my back is like no, I don't think so. I think it's sort of brain-aware somatic memory, it's not brainless somatic memory. So,
well, yeah. It's what comes up as you talk about it is there are so many ways physically that we prepare or that we endure trauma, right? Or stress or tension. We can take it all the spectrum of those. But the fundamental way that we do that is both psychologically and physically is that we brace, right? Anyone you talk to in body work or in trauma work is going to talk about the bracing, the tightening of the teeth, the tensing of the back of the neck, the scalene muscles, etc. And there's a reason that I refer to a large group of different kinds of body workers for my clients as well, right? Because it's held throughout. You find it in the myofascial knots. You find it in, very common. We carry it here, and no surprise that this is the place where we carry the most tension is also the seat of our most fundamental patrolling security dog, right? The brainstem, the nervous system is all centered here, where all of the cranial nerves come down to listen throughout our body. But it is that tightening that plays out again, across domains, right? From blood pressure to the muscles in your back, you're going to see this preparation for something bad to happen.
I just had a crazy idea. I have no idea how you could practically implement this with because you don't know when the trauma is going to happen. But I wonder, given that some of these things use the body in this way to store some of these memories, right? And I wonder if we could make a prosthetic decoy. Like they make prosthetics for extending senses and actuation, right? There's all kinds of prosthetics. I wonder if you could give the stress something else, some other medium to write into that you could then take off at some point. So instead of like locking in your neck muscles or whatever other changes, maybe there's something else that you could be wearing that could be recognized, right? Because the one thing we do know is when you do give people prosthetics, they rapidly, all the stuff by Baki Rita and so on sensory augmentation and substitution. I mean, people learn to use all kinds of really wacky and like evolutionarily novel both sensors and effectors. The extra arms and and weird structures that are just not anything they were prepared for. But that plasticity is there. I wonder if that same system whereby these these stress patterns try to solidify in the body. If we could give them something else to write into, a decoy medium of some sort.
Meaning that the stress reaction would be sort of directed
Yeah,
toward
yeah, yeah.
this vision of like a duck decoy for some reason.
Exactly. I mean, we were thinking, like we've been thinking about, for example, decoys we've been thinking about in the body decoys for metastasis, right? It's like give the metastatic cells something a more attractive place to go to.
You give the dog a bone, he won't eat the couch, right?
Exactly. Give them something, some other kind of bioreactor, something to go into, and then toss it every once in a while. Again, I'm not claiming this is practical with with real patients, but I do think it's interesting that I wonder if you could have some sort of a an integrated wearable thing that let that thing have the stress and not lock up the muscles, so something like that. I don't know, maybe it's nuts.
Well, the thing, it isn't actually, but I mean, yes, on its surface, but but it also isn't, because it's a call and response there, right? The stress is the question, am I in danger? And the answer is no, you are safe, right? And so I'm sure Alexey does this too. The work often is not so much to bring in the stressor itself, but to teach or engender a capacity to have that answer, yes, you are safe, right? So it's call and response. And although in deep trauma work, there is very much a role for symbolism, right? Where particularly with my kids, like I'll say, let's take everything that happened in that house and we're going to put it in a ball. And you are going to design, and we'll draw sometimes all the things that keeps the ball contained, right? They'll draw it in a safe, inside a locked box, inside, etc. And then I will hold it all symbolically and move it toward them or away from them. And they can track the somatic activation, right? And we typically end with them sending it out to outer space where it can't come back unless they give it permission, because they get agency, right?
Yeah. I mean, that's exactly right. That's basically the thing that I was thinking of. But you're doing it with the conscious part, and I'm sort of thinking that exact same thing, but for the somatic part underneath.
Right.
Yeah.
There are things that calm the body, right? There are tones that calm the body, humming practices that soothe, external things that vibrate. That there's I'm spacing on his name right now, Mike, but I remember you would put me in touch with a guy who works with pediatric kids who have to undergo repeated surgeries, and he had practice of it's just bilateral stimulation for calming the nervous system, but it works even when they're under anesthesia, right?
I also wanted to agree with Alex with what you said and with what you said, Michael, but the idea of decoy, or the way to handle the traumatic experiences, I think there's different scales of analysis here, and one of them is a very macro scale, like culture. How do babies handle stress? Mom. We call it in therapy containment, where another presence of another loving human being, caring, helps metabolize the stress. And this is what we do. My colleagues from Holocaust, from Israel, talk about the Holocaust survivals, and they talk about the sense of community that is super important in Jewish culture. That, they had this much bread and they would sit down together and share. In Okinawa, people live longest on planet Earth. The sense of community is extremely strong. But to get back to somatic and biological, I think if we look at the sort of stress regulation, one of the break parameters, one of the things that increases resilience is hippocampus. And their studies, they're a little controversial. We don't know what's the chicken and the egg, is that the size of the hippocampus is one of the predictive factors of resilience. The larger hippocampi people tend to get less traumatized. So if, Michael, you can come up with regenerative medicine to sort of, heal the hippocampus that may have shrunk in trauma, that may increase the capacity to sustain stress. It's just, I don't know. It's just a wild idea, but people do write about that. So.
Well, and we see the brain repairing itself, right? Even with the orphans, the scans, years later showing this improvement. And you're talking about the hippocampus, of course, is sort of the figurehead of the entire limbic system, which is, and we know already that they are, the volume of those organs, those structures in the brain are diminished in people with severe trauma. How do we then facilitate, right, regrowth, the repair? I mean, there are reflexology points and things that are said to stimulate, the pituitary gland or this or that or the other, but whether or not with repeated stimulation and potentially involuntary or subconscious stimulation, if that provokes a physical cascade or not, we don't know.
Yeah, I mean, that's a super interesting relationship with regeneration, because on the one hand, you might think that once we crack regeneration, then we're able to rejuvenate and restore brain tissue, that might help take care of it. But like one thing that we see in planaria is that if you do train them and cut their entire head off, they build a new brain and then they imprint the old information onto this new brain. So some kinds of memories can actually travel and make it into the new tissue. Who knows about this kind of thing, whether these things will be persistent enough that yes, you do introduce new brain tissue into the brain and they go and colonize it. Like I don't know
Right.
how that's going to turn out.
Well, this is the tricky thing, right? With inherited trauma. I mean, there's that study with the mice where, what was it, like 5 generations later, they paired an unpleasant shock with an innocuous smell. I think it was the smell of cherry blossoms. And 5 generations later, without the presence of any kind of nasty shock, their great, great, great grandkids were jumping in the air in terror at the smell of cherry blossoms, right? This stuff is dictated beyond anything that we choose to do because it's protective. And that's where we get this maladaptation, right? We want the next generation to stay alive. We want them to be afraid of dark places and bears and things with big teeth, but we don't want them rocking back and forth in terror, afraid to go outside, because there's a volume control that is currently missing. And I think in modern people right now, we're seeing a much more marked issue with that imbalance, because we are suddenly much more sedentary. There is, for many of us, not all of us, but for many of us, many more resources that we don't have to. I mean, my granddad was struggling for food to stay alive, right? I don't have that problem. Am I wrapped a little more tightly as a result? Probably. It's,
Yeah. Fantastic. All right. Well, I got lots more questions, but I think we'll have to do them next time. Thank you so much for this conversation, and thank you in general just for the work you do. It's unbelievable. It's amazing. So thank you so much.